Well, hello again, y'all, and welcome to the 2022 FDA Retail Food Protection Seminar. Thank you for your patience while we were working through those technical kinks and difficulties there. For those of you that don't know or didn't hear before, my name is Kenya Moon, and I am a retail food specialist here at the U.S. Food and Drug Administration. I would also like to introduce you all to my co-moderator, Ms. Christine Applewhite. And Christine, she's coming live. You want to say hi to the folks?
Hi, everyone. Welcome to our seminar this year. And I will be your monitor on Wednesday. So I will see you then. Thanks, Kenya.
Thanks, Christine. I said we are so excited and thankful that you all have taken the time out of your busy schedules to join us this week at our second annual virtual National Retail Seminar. We have several attendees here across time zones, even international folks have joined us. So once again, welcome. Also, a big shout out and a big thank you to our partners here with the National Association of City and County Health Officials. A lot of you may know them as NACHO. They provided this platform for us, and they have been helping us with the planning and all the technology. So thank you once again, NACHO. It is definitely much appreciated, and without you all, we would not be able to pull off this amazing event. So I hope most of you were able to attend some of the tech check sessions that were held last week. If not, no worries. These sessions were recorded and can be viewed again from the help desk. So if you take a look at your passable screen, you should see towards the top right corner of your screen a help desk tab. There you will be able to click in there and you can see a few frequently asked questions, a few tips for getting the best experience from this online platform, and even how to access some Zoom or live Zoom face-to-face support. We want to ensure that you guys receive as much of an interactive experience and make this seminar experience the best we possibly can for you all. Also, if you've made it this far and you can finally hear me now, I see I have some muting. Hopefully it'll come through for folks, but if you can't hear me, let me know what's going on or send an email. We'll get checked out. So also, if you've made it this far, you should see on your screen a chat. And I see most of you have taken the chat function and have used the chat function. So continue to utilize that throughout the seminar by asking your questions in that chat, also interacting with your peers. There's a button you will be able to respond to comments and reply to comments and things like that. We want to make sure you all engage as much as possible, even though we're not, unfortunately, physically face-to-face this year. So now, without further ado, I want to introduce you to our Director of Retail Food Protection Division here at FDA's Office of State Cooperative Programs, Mr. Andre Pierce. Andre comes to this position with 34 years of local experience at building relationships, sharing knowledge, and promoting action at the ground level where change definitely happens. He believes that quality improvement through the retail program standards can transform food protection programs and make significant impact on reducing foodborne illness risk factors. Andre earned his Bachelor of Science degree in biology from the University of North Carolina, Chapel Hill, and his Master of Public Administration from North Carolina State University. So Andre, I'll pass this over to you. Screen is yours. Please take it away.
Great. Can you all see me?
We can.
Good afternoon. Good morning. From our team at the FDA Division of Retail Food Protection in the Office of State Cooperative Programs, OSCP, it's a mouthful. We're the Office of your Retail Food Specialist, whom you know. And on behalf of the full National Retail Food Protection team, welcome to the 2022 FDA Retail Food Protection Seminar. If you haven't already, put where you're calling from into the chat. I'd like to see that. I noticed someone earlier was calling in from Japan. Incredible. We have over 3,000 attendees this year, participating from over 11 American time zones and 6 foreign countries. We're here all the way from Alaska to Texas, from our tribal nations, from Puerto Rico to Guam, where, by the way, it is now about 3:15 on Tuesday morning. Half a day. Buenos dias. Good day. Welcome, everybody. So glad you're here. Thanks again for coming. A well-planned, dynamic seminar like this one doesn't just happen. It takes the efforts of many people. In fact, plans for this seminar started immediately after last year's meeting based on your feedback. And we look for that feedback after this session as well, after this week. I want to personally thank our presenters who do amazing research, who take their time to prepare and share their research and expertise. Thanks also to our work group members, Kenya Moon, Christine Applewhite, Liz O'Malley, and the NACHO team, and many others who I don't want to exclude, who've been working with patience and flexibility to program this year's meeting. And of course, our host, who Kenya mentioned, the National Association of County and City Health Officials. And a special shout out to the tireless efforts of our team, the retail food specialists, who are so committed to bringing you relevant material for your day-to-day work. The reach of this virtual meeting is amazing. FDA provides this forum for you, the state, local, tribal, and territorial regulators, our nation's environmental health specialists, to discuss current and emerging issues related to food safety. This venue helps connect folks from over 2,500 jurisdictions across this country to discuss significant challenges you find in your retail establishments, and they're different from where you work, place to place, and to learn innovative ways that you address them. The seminar is part of the FDA compliance program for standardized staff to attend these meetings. And on that note, congratulations to the newly FDA standardized inspection officers who will be recognized tomorrow in the breakout sessions. I charge you to use your credentials to standardize others deliberately and with a fury, so our efforts at uniformity can cascade through and be multiplied throughout your staff. The retail food seminars began in 1987, I believe, as 6 regional seminars where we met to learn and network. I've had the opportunity to go to several. When I asked for the history of the seminars, one of our retail specialists replied with a nostalgic, "How could you forget the shrimp cookout by the fire in Michigan?" Indeed, these seminars have fostered professional connections and friendships that have spanned years. And many of you, if you look at the participant list and you look at the names coming through the chat now, no doubt you'll recall old friends and colleagues who helped us in our careers. And that's really exciting to see today. We're missing one colleague in particular this year, Dr. Brian Newmer. He passed away last month. He planned to present at 2 of tomorrow's breakout sessions. Dr. Newmer was a food safety leader, a teacher, and mentor to so many of us. A colleague from CIFSAN shared this, and I want to quote, "Dr. Newmer's impact on food safety with the Conference for Food Protection went beyond committee work. I met Brian through work on the CFP Executive Board, where he was always friendly, knowledgeable, and professional. He focused on getting solutions and helped all to capture a clear vision for food safety." Indeed, Dr. Newmer's diligence, commitment, and willingness to promote food safety research and education made a tremendous impact on many people and organizations. Yes, this forum fosters lifelong relationships and connections that can stimulate innovation in food safety. We learn so much more together than we do independently. More than half of you attending this seminar this year are new. Use the opportunity and face-to-face opportunities in the future to meet colleagues, to start building the lasting relationships that will help us brainstorm innovative solutions. Now, let's talk about our seminar and the reason we picked this year's focus, norovirus. Statistics tell us that 1 in 6 Americans get sick in this country every year from foodborne illness. Statistically, almost 500 of us here on this call today will be affected. Now, I'd like you by a thumbs up or another emoji to put in the chat how many of you personally or know someone who are affected this year by foodborne illness. And each year, foodborne illness results in 128,000 hospitalizations and some 3,000 deaths. But they're only statistics. And some of you are chatting here now. They're only statistics until it affects you, right? Your child, your spouse, your elderly parent. The goal of FDA's National Retail Food Team is, like yours, to reduce the occurrence of foodborne illness risk factors at retail facilities. It's a goal we all share. We can do this by promoting uniformity and consistency in our outreach and our inspections. It's our first strategic goal of our team and is yours as well. One of the first meetings I attended, as Kenya said, I came here in January. One of the first meetings I attended was at a virtual meeting in January, Healthy People 2030. It met in Atlanta. Something struck me significantly. It was the impact of norovirus at retail settings. I had an opportunity to hear research from CDC about the linkage between food code provisions, specific provisions in the code, like bare hand contact, and the occurrence of norovirus outbreaks. CDC's 2017 annual report showed that well over half foodborne outbreaks in this country are associated at retail. And of those outbreaks, norovirus was the most common cause of confirmed single cause outbreaks. Have you heard the analogy of the three-legged stool? It's also associated with foodborne illness, especially with how it relates to norocontrol. And it's a mnemonic that I've used to help me remember these things. 3 legs of the stool represent hand washing, no bare hand contact, and healthy employees. When all the legs of the stool are in place, you have solid seating. You have a solid foundation for norocontrol. But if any one leg fails, things get dicey. FDA's national risk factor studies show that we have made significant progress in the area of no bare hand contact, and that is thanks to you all. Our continued challenge is how to really improve compliance with hand washing and employee health. And we really want to look at the types of intervention strategies you're using and how we can replicate those and share. With this report from CDC and these concepts in mind, this year's seminar will focus on norovirus, including assessing employee health, investigating norovirus-related foodborne illness, and implementing employee health intervention strategies. Based on your feedback from last year's conference, we've really tried to incorporate agenda items that are relevant to your day-to-day jobs. We've got a well-organized full schedule this week. There's something for everyone. So I'm just going to briefly go through this. I'm sure you've looked, but I want to call a couple of points out. In today's general session, I look forward to hearing from CDC's research on the assessment of regulations and how they affect outbreaks of noro. We'll also learn about innovative research on norovirus vaccines. And we'll hear a lot about the value of making relationships before the outbreak, as well as the power of collaboration. And we'll talk about, we'll have a panel on the Association Collaborative. Now, tomorrow's sessions are geographic breakouts that span 10 hours in order to cover time zones. While they're organized by areas, keep in mind they're open to everyone. Feel free, as you attend the meeting this week, to jump from one to the other. You may decide that you would like to hear about creating a food safety culture and active managerial control at the 1 o'clock session tomorrow in the Southeast. Then you might want to jump over to the USDA FSIS update in the West after the breakout has ended, after the Southeast breakout has ended. NACCHO has developed an excellent platform that will give you this flexibility. Plan your agenda to glean what is most helpful for you. And also, I understand these sessions will be available for up to a year afterwards. So if you miss one, it's chock full. On Wednesday, there's another general session with topics like verbal judo. Those are the soft skills that make all the difference at influencing culture, which is what we are about, is changing that food safety culture in the kitchen and assessing employee health and much more tomorrow on Wednesday. And finally, on Wednesday, the seminar technically ends, but on Thursday, on Wednesday, the seminar ends, but on Thursday, we have the risk factor study workshop. We at FDA want to encourage you to conduct risk factor studies in your own communities, so you identify the unique gaps and design intervention strategies that resonate with your operators. In my local government experience, we conducted 3 data collections over 10 years. We could not have done our risk factor studies without this type of training from our own retail specialists. Really proud of our team this year for developing such a resource for this year's seminar. You're in store for a great 3-day seminar and workshop. So thank you again for coming. I want to close today with some thoughts about a word, willingness. Really think about willingness now and how important a trait it is at getting things done. I'll share a quote by Atul Gawande, an American surgeon, writer, and public health researcher. And take this to heart. Better is possible. It doesn't take genius. It takes diligence. It takes ingenuity. And above all, it takes a willingness to try. Willingness is a trait we can work with. Our willingness to try is so much more powerful than our wit or genius. I'm confident that together we can harness our willingness, and I'm sure we will make things better. Folks, I really hope you enjoy this week's seminar. Let's get started. Thank you. Kenya?
Thank you so much, Andre, for those enthusiastic and very welcoming words. And like to piggyback off of what Andre said, we truly hope you guys enjoy this week. Everything we've done this week to put the seminar together is for you all to ensure that you all have a successful and enjoy the seminar. So without further ado, I would like to introduce you to our next speaker, which is going to be our very dynamic keynote speaker, Dr. Laura Brown. Dr. Brown works at the Centers for Disease Control and Prevention, leading the National Center for Environmental Health Safe Food Section. This team conducts research and surveillance on retail food safety and foodborne outbreaks. Dr. Brown has worked on a variety of food safety topics, including ill food workers, hand hygiene, and food cooling practices. So without further ado, I ask that you all join me in welcoming Dr. Laura Brown. Dr. Brown?
Hey. Can you see me and my slides? I'm assuming that's a yes.
Yes, you're good.
Okay. First, I want to say go Wolfpack to Andre. I went to North Carolina State University. I'm always excited to meet other alumni. So I did not know that. So thank you. I'm excited about this opportunity today. I'm going to talk about some CDC data on foodborne norovirus illness and outbreak prevention. First, just real quickly, I'll give you an overview of who's speaking today. I'm with the Division of Environmental Health Science and Practice in the National Center for Environmental Health. We are really focused on supporting environmental health professionals. So what I'm going to talk about today is our work supporting environmental health professionals in the area of retail food safety. And then our second CDC speaker is Anita Kampambadi. She's with the Division of Viral Diseases, and she's going to be talking about some of the work that we just heard about, looking at food code provision adoption in norovirus. So I'll do this quickly because we've already covered it. Just want to talk a little bit about why foodborne norovirus in the retail setting and preventing it is important. It's a significant public health issue. It causes the most illnesses and outbreaks among foodborne diseases and causes the 4th and 5th largest amounts of hospitalizations and deaths. And a lot of people get sick and a lot of people miss work because of norovirus. It leads to really large productivity losses. And restaurants are the most common setting for these outbreaks. Over half are associated with restaurants, and then 17% are associated with catering and banquet halls. Now, CDC data from outbreak investigations tell us that most foodborne norovirus outbreaks have an infectious food worker as the source of contamination. And then of those, most of those were linked with foods being contaminated during final preparation, so in the last step. So we know that infectious and ill food workers is important, and we know that it's happening in the restaurant for the most part. Now, it's worth noting that we don't always collect these data on outbreaks. We don't always know what the contributing factor is. We don't always know where the contamination occurred. But this is what we do know from those outbreaks, where we can identify those things. Again, this is information you guys probably already know, but the FDA Food Code recommends several steps that we can take to reduce and prevent foodborne norovirus outbreaks. First, we can prevent infectious workers from working. If they aren't working, they can't contaminate the food. We also can prevent bare hand contact with ready-to-eat food to reduce the chance for contamination. We can practice good hand hygiene and clean and sanitize food contact surfaces. So with that sort of context on the importance of norovirus prevention in the retail food setting, I'm going to jump right into talking about CDC data on this topic. I'm going to summarize several sets of data today. Two of them are outbreak data. They're from CDC's National Environmental Assessment Reporting System. So this system collects data from environmental health investigators on the environmental health component of foodborne outbreak investigations that happen in retail food settings. So these data really focus on trying to understand how the outbreak occurred and why the outbreak occurred. And these data are really valuable to thinking about prevention. So the first data set I want to talk about, excuse me, looks at links between what restaurants do and norovirus outbreak size. So our data set, the data that are collected in years, are only collected on outbreaks. So we wanted to think about how can we look at relationships between what restaurants do and food safety. So when environmental health professionals go in to do an outbreak investigation, they do a number of things, and they report some of the data that they collect back to CDC's NEARS. So they interview managers and workers about policies and practices. They observe practices in the restaurant. And so I'm going to talk about sort of three sets of those data today. Data collected on food safety training and certification in these outbreak restaurants. Data collected on food safety policies, so ill worker policies and cleaning policies, and then data on practices observed in the restaurant. And because we're looking at norovirus specifically, we are focusing on things that we think should be related to norovirus prevention, like ill worker policies and bare hand contact and glove use, those kinds of things. All right, so what do those data tell us? Well, we find that norovirus outbreaks are smaller in restaurants with a policy requiring workers to tell managers when they're ill. So you'll see here, this top bar is outbreak restaurants that don't have a policy requiring workers to tell managers when they're ill. And you'll see the average norovirus outbreak size in those restaurants is 29, so 29 sick people on average. This lighter blue bar you see is the average outbreak size for restaurants that do have a policy. 19 is the average number of sick people. So you see a significant difference here of 10 ill people essentially, based on whether or not the restaurant has this ill worker policy. Norovirus outbreaks are smaller in restaurants that provide food safety training to workers. And again, you'll see the data here. At the top dark bar is the average outbreak size for restaurants that really don't provide any food safety training. So that's an average of 28 ill people. And then you can see it drops down a little bit by the type of training. And then you'll see outbreak restaurants that provide both classroom and on-the-job training have an average outbreak size of 11. Again, a pretty big difference based on the training provided. Norovirus outbreaks are also smaller in restaurants with a certified kitchen manager, 26, on average, 26 ill people versus 17 ill people. And then norovirus outbreaks are smaller in restaurants in which the workers are observed wearing gloves. The environmental health investigators go into the restaurant. One of the things they look for is our workers wearing gloves. And again, you'll see a difference of about 11 ill people when gloves aren't worn. When gloves aren't observed, the average outbreak size is 28. When they are worn, it's an average of 17. Now, these data are remarkable to me. I think they really demonstrate that actions that restaurants can take can mitigate the impact of outbreaks. Now, it's important to note these data are not causal, they're cross-sectional. We did try to control for all the things that we thought might make a difference, like the whether or not the restaurant was a chain or independent, and the size of the restaurant. But these consistent findings really suggest that the actions that restaurants take can make a difference in mitigating norovirus outbreak size. So one way to look at these findings is through the lens of food safety management. Sure, you guys are familiar. I'll just do a quick review. A restaurant has a strong food safety management system if it has food safety procedures and food safety training, and then it monitors to make sure that food safety procedures are being implemented. Strong food safety management leads to active managerial control over food safety in the kitchen. So the data I've just presented on outbreak size really fits nicely into this scheme, at least for procedures and training. Our data show that the presence of an ill worker policy is related to smaller norovirus outbreaks. We also found, I didn't present these data, but we also found that establishments that have cleaning policies have smaller outbreaks as well, so that fits there. And then restaurants that have training and certification on food safety have smaller norovirus outbreaks. Now, we didn't do such a great job assessing monitoring in this particular data set. So we don't really have a data point here. It doesn't necessarily mean that we didn't find anything. It's just we weren't able to assess this relationship. Okay, so that is the one set of data I wanted to present to you today from NEARS. The second one is, again, also norovirus outbreaks. And we're currently working on this. So I'm presenting preliminary data here. We hope to publish this in 2023. So this one focuses on the antecedents or the root causes of norovirus outbreaks. Basically, we're trying to understand the factors that lead to the contributing factors that lead to ill workers working in restaurants, and then that consequently leads to the outbreak. So one of the things we ask our investigators who report data to NEARS is, once they've compiled all the data for the outbreak investigation, they've talked to all their counterparts, they're synthesizing the data, we ask sort of an open-ended question about what do you think were the antecedents or the root causes to this outbreak? Now, of course, investigators can't always tell us this. It really depends on the outbreak and what they've learned. But in many cases, they do have a pretty good understanding of what happened in that restaurant. And so in those situations, we ask them to tell us what they think. And so what you see here are the sort of the top 5 categories that our investigators report to us about norovirus outbreaks. And here we're talking about a data set of 423 norovirus outbreaks. The most common antecedent was lack of managerial oversight and policy enforcement. So top left for me. So managers weren't making sure that procedures concerning ill worker and hand hygiene were followed. The second antecedent to these norovirus outbreaks was a lack of training on processes. There might have been processes, but there wasn't enough training for the food workers on those processes. Lack of food safety culture was also a top antecedent. Essentially, staff did not see food safety as a priority. Now, in some cases, the establishment had food safety procedures, but they didn't follow them, or they had procedures, but they were really insufficient to provide protection. And then the 5th antecedent mentioned by our investigators was lack of sick leave or other financial incentive. So investigators felt like this antecedent was related to ill workers came to work when they were sick because they didn't get paid if they didn't, or there was no other sort of system to help compensate for a loss of income that they would experience from not working. Again, I think it's helpful to look at these findings through the lens of food safety management system. You'll see here, sort of categorized for you. Lack of procedures, insufficient procedures. This data set suggests that these are antecedents to norovirus outbreaks. Failure to follow those procedures is another antecedent. Lack of training and certification is an antecedent to norovirus outbreaks. And then lack of managerial oversight. It was identified by our environmental health investigators as an outbreak antecedent. Again, these data suggest that a lack of procedures, a lack of training, lack of monitoring are root causes of norovirus outbreaks. So I'd like to present a third set of data that we collected at CDC. Now, these are not outbreak data, and these data are not new data. We collected these 10 years ago, but I do feel like presenting them in the context of these other data sets is really helpful. So for this study, we simply interviewed managers and workers in randomly selected restaurants. And this study was an environmental health specialist network study. Some of you may have heard of this. It's a cooperative agreement, CDC funds, state and local health departments to collect data in restaurants. So for this study, we simply interviewed workers and managers. We asked workers how often in the past year they had worked a shift while they had vomiting or diarrhea, so symptoms of foodborne illness. And then we asked them some other questions trying to get at why they had worked while sick. So some of their beliefs and their attitudes, some of the factors that influence their decisions to work or not to work. And then we also interviewed managers about the restaurant itself, about the training provided at the restaurant, policies and procedures, those kinds of things. And then we took those two sets of data and put them together to try to look at the links. And we did find relationships between restaurant characteristics and what workers told us they did, whether workers said they had worked while sick with vomiting or diarrhea. Workers in restaurants with less experienced managers were more likely to say that they had worked a shift in the past year with vomiting and diarrhea. Workers in restaurants that did not have a policy requiring workers to tell managers when they were ill, those workers were more likely to say they had worked while ill. Workers in restaurants that didn't have a plan for when workers called in sick, so they didn't have a system in place to deal with, to find a replacement, for example, for an ill worker, those workers were more likely to work while sick. Workers who had concerns about short staffing if they didn't work, so they were thinking about not coming to work. One of the things that concerned them was whether or not their coworkers were going to be short-staffed if they didn't come to work. Those workers were more likely to work while sick. And then again, workers who were worried that they would lose their job if they didn't work. So again, they're considering whether or not they are going to go into work. If this was a concern for them, that they might lose their job if they didn't go into work, those workers are more likely to work while sick. These data indicate that, again, restaurants' policies and practices can have a real impact on worker behavior. And again, I'll put this in the context of a food safety management system. A lack of procedures, so a lack of a staffing plan and a lack of an ill worker policy led to workers, or was related to workers reporting having worked while ill with vomiting or diarrhea. Less experienced managers, and here I'm classifying this under sort of a lack of training. Restaurants with less experienced managers had workers who were more likely to say they had worked while ill. And again, for this study, we didn't do such a great job of assessing monitoring, so we really can't, we just don't have a data point on that. Okay, so that's a lot of data. I really tried to keep it a high-level summary. I can certainly provide you with the articles, the research articles that these findings were based on. For now, I'm going to try to do a summary of the summary. All of these data sets indicate that food safety management system components are consistently linked with food safety in retail settings. We found that establishments with training and specific policies have smaller outbreaks, and that antecedents to outbreak consistently include a lack of training, a lack of processes, and a lack of managerial oversight. We also find that workers are less likely to work while ill, less likely to tell us that they had worked while ill with vomiting or diarrhea if their restaurant had an ill worker policy, it had a plan for short staffing, and it had an experienced manager. Taken together, these data really suggest that there is a link between management systems, what management does, and food safety. We also see that staffing issues and economic issues are a particular concern. So if we're thinking about designing a food safety management system to address ill workers and norovirus, it would need to focus on staffing and economic issues, really, for effective norovirus prevention. So key takeaways here. There's really no one simple trick, which is disappointing, but that also seems to be describe life. There's no one simple trick. Strong food safety management systems are key. Management is key. What management does makes a difference. Again, strong food safety management systems are linked with some smaller norovirus outbreaks. Their lack is linked with outbreaks and with workers working while ill. And then the final point is that staffing and economic issues really need particular attention from management. So that is my very high level summary of some data sets that CDC has on norovirus. And I think are we moving straight on to the next presenter? Or are we taking questions?
Yes, we can go. I'm scrolling through chat here, not many questions, Dr. Brown. I do want to thank Adam Kramer for putting the link to the CDC website for the data into the chat. Thank you. There was a couple of questions about that. And a couple of folks also asked if the presentations would be available. And for those that didn't see the comments, we have made PDF versions available if speakers have agreed. So they will be posted after the sessions today. So thank you all for that. And we're going to move right along. Let's see, make sure there's no questions I'm missing here. So I'm going to go to our next speaker, but thanks again, Laura and Dr. Brown, for giving us an excellent presentation. A lot of good information, and it was well received. A lot of positive comments were going through chat there. I'm not sure if you had access to see that. Our next speaker is also going to be from the CDC. Our next speaker is Anita Kambampati, and Anita is an epidemiologist with the Viral Gastroenteritis Epidemiology Team in the Division of Viral Diseases at CDC. Her work focuses on the epidemiology, surveillance, and prevention of norovirus. She holds a Master of Public Health degree from the Rollins School of Public Health at Emory University. So Anita, the screen is yours.
Thank you so much. Can you hear me?
Yes, you're good.
Awesome, thank you. I'll just wait for the slides to pull up. Thank you so much. Okay, hi everyone. My name is Anita Kamampati, and I'm with the Viral Gastroenteritis Epidemiology Team at CDC. Today, I'll be presenting an update of an analysis that we conducted a few years ago, looking at norovirus prevention measures in the FDA food code. So this is the work that Dr. Pierce was referring to. Yeah, excited to speak to you all. Next slide, please. Okay. So as you all have heard, norovirus is the leading cause of foodborne illness, as well as foodborne outbreaks in the United States. From 2009 through 2012, it accounted for almost half of foodborne illness outbreaks with a single known cause. It's also one of the leading causes of foodborne hospitalizations and death, and costs approximately $2 billion annually in healthcare expenses and productivity losses. We can go to the next slide. So CDC collects outbreak investigation data through a few different systems. When we think about norovirus outbreak surveillance in terms of the epidemiologic triangle shown here, epidemiologic data on the hosts or the population affected by the illness are reported to NORS, and that's the National Outbreak Reporting System. And then we have molecular data on the agent causing the illness, so norovirus in this situation. So those data are reported to CoLICINet. Then finally, we have data collected on the environment, which allowed the agent to infect the host. And these data are reported to NIRS, and you heard Dr. Brown talk a little bit about that. So taken together, these data provide a comprehensive picture of norovirus outbreaks in the United States. Next slide, please. So in 2014, CDC published a summary of foodborne norovirus outbreaks reported from 2009 through 12. This resulted in a few key findings that provided the foundation for much of our work on norovirus as it relates to food safety. Next slide, please. So I'm just going to give you some background on the pathogen and why it's so easily spread. And this is really the foundation for many of our recommendations. Noroviruses have an incubation period of about 12 to 48 hours, after which infected individuals will generally suffer from sudden onset vomiting and or diarrhea. Most people will generally recover within about 3 days, but about 10 to 12% of people will seek medical assistance. And some people will, of course, experience more severe illness. However, about a third of illnesses are subclinical, so people might experience very mild or no symptoms at all. And this is really a key for some of our prevention strategies. So next slide, please. So once an individual is infected, viral particles are shed copiously both in stool and vomit in the order of 100,000 to 100 billion viral copies per gram of feces. Shedding can occur for several weeks, and this can happen after symptoms end, which is another important point to consider. So this all coupled with the fact that it takes very little virus to make an individual sick, as few as 18 viral particles, means that norovirus is very well adapted for transmission. We can go to the next slide. So of course, norovirus transmission can occur in a number of ways. This includes direct person-to-person contact, consumption of contaminated food or water, and contact with environmental surfaces that have been contaminated with the virus. So all of these routes of transmission can occur in our setting of interest today, retail food establishments. So we looked at over 1,000 foodborne norovirus outbreaks. And as I mentioned on that first slide, these constituted almost half of foodborne outbreaks with a single known cause. While foodborne norovirus outbreaks can occur pretty much anywhere, and you can see schools and daycares and private residences here, the vast majority occur in food service facilities and specifically restaurants. So then when we looked at the characteristics of these outbreaks, we found some common themes. So of 520 outbreaks that identified factors contributing to contamination, the majority, over 70% of these outbreaks, implicated ill food workers. And specifically, over half of those outbreaks indicated that the contamination was caused by bare hand contact with ready-to-eat food. We also noticed that of those outbreaks that implicated a specific food item, about 75% were foods that were eaten raw. So think about your lettuce, your tomatoes, foods that are prepared without a kill step at the end there. Next step here, next slide, sorry. So these findings really reinforce the need for improved compliance with CDC guidelines, as well as underscore provisions in the FDA Model Food Code. Specifically, these recommendations include practicing proper hand washing and minimizing bare hand contact with ready-to-eat foods, having certified kitchen managers and training food service workers in food safety, and excluding ill staff both during and shortly after symptoms end. And this is really in order to address that post-symptomatic shedding. Let's go to the next slide. So as I mentioned, these recommendations are outlined in the FDA Food Code, and this is updated every 4 years. Adoption of the Food Code, however, in whole or in part, is at the discretion of state and local governments. And given how important these recommendations are for prevention of foodborne illness, we really wanted to address state-specific adoption of 5 provisions that we specifically identified to prevent norovirus. So these are listed on the slide here. So the first one was a requirement for hand washing. The second was prevention of bare hand contact with ready-to-eat food. The third was exclusion of staff who are ill with vomiting and diarrhea for at least 24 hours after symptoms end. And you'll notice that this is not just norovirus, it's all vomiting and diarrhea. And this is because people don't often test for norovirus. The fourth one was a requirement for a certified food protection manager. And then finally, we looked at whether they had a response plan for contamination events, such as public vomiting. So we then compared the food codes of all 50 states and DC to the 2013 FDA Food Code which was the most current version at the time of our analysis. And we coded a state as having adopted the provision if it was in effect as of December 31st, 2014. Next slide, please. So here we show the states that adopted each provision shaded in blue. And at the time, all jurisdictions had adopted in some form the hand washing provision. So it's not included on these maps. But as you can see here, there was substantial variation in adoption of the other provisions at the time of this analysis. Okay, so let's go to the next slide. So we then looked at associations between state adoption of these provisions and almost 1,500 foodborne norovirus outbreaks that were reported to CDC from 2009 through 2014. So this figure shows the reporting rate of foodborne norovirus outbreaks among states that did adopt the specific provisions, and these are represented by the blue boxes, and then those that did not, and these are represented by the red boxes. So we found lower rates of reported foodborne norovirus outbreaks in states that adopted the provisions compared to those that did not. And this really suggests a potential impact of adoption on reducing incidence of foodborne norovirus. So of course, as with any analysis, there are limitations. Among others, we were only able to assess adoption on a state level. So there might be additional regulations at the county or local levels, or even at the individual restaurant level. Further, we were not able to assess compliance with adopted regulations. But the goal of this analysis was really to identify gaps in legislation in order to provide actionable areas for improvement. So we can go to the next slide. So with any public health goal, there's often a moving target, and we want to make sure that we're as up to date as possible with the latest science. So like I mentioned, an updated food code is published every 4 years. And in 2017, FDA released a new version of the model food code. So given this, in 2020, we sought to assess the adoption of the same provisions I mentioned, this time as included in the 2017 food code. So the bare hand contact and ill staff provisions stayed the same, but there were two notable changes to the 4 provisions that we wanted to assess. So the 2017 food code requires that the person in charge, so not just any employee, is a certified food protection manager. And also the response plan for contamination events, we now require this to be written. So with this in mind, we took a look at the changes in the state adoption of these provisions as of March 2020. And then the next slide, excuse me. So this first provision, prohibition of bare hand contact with ready-to-eat food, is very crucial for norovirus prevention, as we've seen with our outbreak data. So in 2014, we saw that 39 states, or 76%, adopted a provision expressly prohibiting bare hand contact with ready-to-eat food. And since then, we've seen some additional uptake. So now 45 states, or 88%, prohibit bare hand contact. So moving in the right direction for sure. Let's go to the next slide. So again, another extremely important provision for norovirus prevention is the exclusion of ill food workers for 24 hours after symptoms end. And again, this is really to address that post-symptomatic shedding that we know occurs with norovirus. We also know that, like I said, testing is not very common for norovirus, so it's generally self-limiting, and that norovirus is the leading cause of AGE. So even though there is a provision in the food code that is specifically for norovirus exclusion, we wanted to look at whether states had adopted the provision that excludes any food worker with vomiting and diarrhea, regardless of the diagnosis. So in 2014, we saw that 30 states required this, and we've seen an increase in that to 40 states, or 78%. And these require at least that amount of exclusion time. So some, I think there's a couple that require 48 hours. So this is, again, really helpful for that post-symptomatic shedding. Next slide. Okay. Yeah, so these next two provisions have changed a bit from our previous analysis. So at the time of our last analysis, the last two were the most recent additions to the food code. They were added in 2011 as a supplement to the 2009 food code and then formally included in the 2013 food code. But like I mentioned, the latest language in the 2017 food code requires that a person in charge specifically be a certified food protection manager, so not just any employee. When we looked at this in 2014, that was not the case. And at that time, 26 states did require a certified food protection manager, but only 5 states have adopted the new requirement that the person in charge is a certified food protection manager. So we do have some work to do here. And finally, looking at the response plan for contamination events, this was our least commonly adopted provision during the last analysis. But despite the change that this plan be written, we do have 9 states, or 18%, that have adopted this provision. So we do have some next steps lined up for this analysis. Since we have a few more years of outbreak data, we are taking a look at that in conjunction with these adoption, with the adoption of these provisions, excuse me. We're examining potential associations with reporting rate and outbreak characteristics. This analysis is currently in progress, and we're targeting publication later this year or early next year, at which point we'll be working with you all to disseminate the findings and hopefully encourage more states to not only adopt more of these provisions, but also to enforce them. So with that, I'd like to conclude. I'd like to acknowledge my colleagues here at CDC, as well as our state, local, and regulatory partners. Thank you so much.
Thank you, Anita, for that great presentation, a lot of information. We did receive a couple of questions. I don't know if they didn't specify if it was for you or for Dr. Brown, so we'll just throw it out there and see if anyone wants to address. One question was, do we have any data on the spread of norovirus through street-based vendors?
Anita might have a better question than I. We get questions like this a fair amount, like, do we have outbreaks associated with cottage foods? Do we have outbreaks associated with street vendors? And I'm going to say not much. Anita, correct me if I'm wrong.
Yeah, so thanks for the question. So we do collect setting of the outbreak in NORS, the National Outbreak Reporting System. We have not specifically looked at the street-based vendors just yet. But again, this is kind of a newer setting. So certainly something to look at, but not too much data on it just yet.
Thank you for that. And the next question has to do a little bit with home testing. And I know later we actually have a presentation on norovirus vaccines that offer home testing for norovirus. And if so, would this be a priority and under what circumstances?
Thank you. Yeah. So, I mean, with norovirus, the key is really kind of that staying home while you're sick and, shortly thereafter. So if you are having vomiting and diarrhea, especially, in a situation where there's not something else going on, stay home if there's ever a doubt. Stay home if you can. It spreads quickly, so before you can even test for it, you might have already spread it. So really excluding ill workers. And then again, cleaning and disinfection is really important. So not only, cleaning the environment that the vomiting event has occurred in, perhaps a bathroom or sometimes these occur on the floor, but their surrounding radius as well. Norovirus does aerosolize, so can spread to the surfaces outside of that. So really just effective cleaning and disinfection, and of course, staying home while you're in.
Thank you for that. Yes, let's follow those food code recommendations. Definitely. I think that'll take care of it there. And I think this is the last question I see in chat. Does data show us, is there less noro in states that have adopted these food code changes? Do we have any data to answer that question as of yet?
Yeah, so the slide that I showed with kind of that outbreak reporting rate with the blue and red boxes. So that was specifically looking at foodborne norovirus. Yep, that's it. So we did see that the reporting rate of foodborne norovirus outbreaks was lower in those states that had adopted the provisions versus those that did not. So those are in red. The ones that did adopt were in blue, and you can see that reporting rate lower in those states. So again, there's definitely layers between adoption and enforcement and how that trickles down, but we do see a difference there. Laura, feel free to add anything else just in terms of on the ground what we're seeing.
Yeah, no, I think these data are powerful, and I think combined with the data on outbreak size showing that what happens in the individual restaurants is linked with norovirus outbreak size, I think the evidence is fairly strong that these kinds of interventions make a difference.
Definitely. And I believe, let's see, is there any other questions? Okay, we have another question here. For states that have multiple regulatory agencies, was data obtained from all the agencies for provisions that had been adopted, or only the lead agency for foodborne illness investigation?
Yeah, so that's a great question. So we looked at adoption on the state level, whoever the agency was responsible for adopting the food code in that state. So there was one, if there was one agency, we looked at one agency. If there were multiple agencies, we looked at multiple agencies. But again, this was kind of that whoever was responsible for adopting it in that state. And there was a back and forth process. So we did go back to the states and say, you know, hey, this is what we have for your state. Do you have any corrections? And made those corrections as we saw fit. And then the outbreak data are as reported to NORS. So public health departments report to NORS. So these data are as reported by the state.
Excellent. And let's see, we've got a little more time, so we'll grab a couple more of these questions here. We have a question in the chat. It says, how easily is noro spread through aerosol from vomiting?
Yeah, so we do see this happen in restaurants, and it often happens when someone has a public vomiting incident and, you know, kind of spreads to their surrounding areas. So we do have some various outbreak reports that showed, you know, folks sitting, I think it was at a banquet hall or a wedding, and there was a vomiting incident, and the viral particles did aerosolize, spread to the other tables. Folks, you know, continue to eat, and there was some spread there. So there was proximity to the vomiting incident. Various outbreak reports have seen with increased cases. So yeah, and norovirus is a very hardy virus, so it persists on the surface. So when it does aerosolize, it kind of sticks around. So that's the real need for the effective sanitization of those surfaces, especially once someone does have a vomiting incident.
Very good. And along those same lines, we have another question. Someone said that we know cruise ships are commonly known for their large spreads of norovirus. So they're wondering, were cruise ships included in this particular study?
Yeah, so that's a great question. So although norovirus is a large cause of outbreaks on cruise ships outbreaks only account for about 1% of all reported norovirus outbreaks in the United States. And they're actually managed by a separate program at CDC, and they're not reported to NORS. So they were not included in this data set. So NORS is outbreaks that occur in the United States. So since these outbreaks occur on a vessel, not necessarily in the United States, these are kind of reported separately. But thank you for that question.
Very good. I think that answers the question too. We had some comments earlier. Folks were wondering who's regulating cruise ships and all this type of stuff, and we had some answers going around, so that addresses that. So thank you definitely for that, Anita. Let's see, we have Discussing gaps. What are some of the most important data gaps regarding norovirus right now?
Yeah, so a lot of our work on norovirus right now is kind of building the evidence base for a vaccine, and we're hoping that'll come out within the next 10 years. So kind of really looking at who to target that vaccine towards, what is the best public health outcome that will come from targeting of that vaccine. So really trying to work on, do we vaccinate the children? Do we vaccinate kind of restaurant workers? What's the best population to target? So a lot of our work focuses on that right now.
And from a different perspective, a lot of our data show us sort of what works. Like it works to prevent ill workers from working, right? And we know that it helps reduce norovirus transmission. So I think what we need now are to really focus on some identifying interventions that can keep workers home, for example, can keep ill workers home. So some of that practical application is I think what we need to be thinking about now. In addition to a vaccine would be great.
Hey, it's coming. We'll have information on that later this afternoon. And also, let's see, we got, this may be outside of the purview that you guys have done at CDC, but we'll ask the question and see. We had a person ask, how about norovirus among children in school? Do we have any data on that?
We certainly do. So school outbreaks are a common thing. They happen every single year. There's quite large school outbreaks. In fact, many that have happened. I can pop a link in the chat for an analysis that was recently published from our group looking at school and daycare outbreaks over the past 10 years. So yeah, certainly another setting of concern, one that we are actively hoping to address.
Excellent. All right, I think let me see. Christine, do you see any other comments that or questions that I may have missed? I think we covered the gist of most of them. We've got one more just popped in there. Do you utilize wastewater surveillance in tracking or monitoring unreported outbreaks?
Yeah, so another great question, and one that is definitely a topic of conversation these days. So this is not an area that I'm currently working on, but there's a lot of talk about it and looking to see the applications of wastewater surveillance for norovirus.
Very good. And another one that's popped in there, this is kind of relevant because currently FDA, we're doing our risk factor study in grocery stores, but a question came across, is there any data about grocery store and supermarket versus restaurants? Yes, I'm assuming it pertains to norovirus.
Yeah, so like I said, we do collect all outbreaks of norovirus in NORS that are reported by the states outside of this cruise ship outbreak. So the setting is reported for outbreaks in which there is those available data. So that does include grocery store and supermarket outbreaks. We haven't looked at these specifically recently, but yeah, we do have data on this.
Very good. So we've got a few more minutes for a break. I don't know, any other closing comments from you, Dr. Brown, or Anita, anything else you guys want to close with? But we thank you again for presenting today. Oh, sorry, go ahead, Dr. Brown.
Yeah, thank you for the opportunity. It's always great to talk about our work to the people that can do things with it.
Yeah,
Great information.
I echo Dr. Brown. It's really a great opportunity to talk to you all and work with you all to reduce norovirus in the United States.
And thank you once again on behalf of FDA and the seminar planning group. Like I say, it was obviously good information because chat was going. I don't know if you were able to look at that while you were speaking, but they're thanking you right now, even in chat, and it was great information. Like I said, very relevant and something that our folks that are on the call can take and hopefully use back in their day-to-day life for the jurisdictions. So with that being said, I'm sure folks are almost ready for a break now. But before we get into the break, we've got a few more minutes. I want to draw your attention once again to those little tabs at the top of your screen. One of the tabs you may see is something called a conversation tab. So if you take it's right next to the FDA Teams tab. You should see the word conversations. If you tap on that, you'll see how to get to your personal inbox and also for the chat boards. Now, if you haven't taken a look at those chat boards, I encourage you to do that during the break and between speakers and whatnot, because we've got some interesting discussions going on already there. So there's some great things, talk about some of those inspections you had, tell us about some of those intervention strategies that y'all have come up with in your jurisdictions, and share with your peers here on the line. So take a look at those chat boards and discussion tabs there, and join in those conversations. All right, so let's take a break here. We are scheduled the next sessions will start at 25 minutes after the hour. So you have a little bit over a 10-minute break. You will need this session is going to close out. So you will need to click on that next session on your agenda card, and then it will start from there. And so enjoy your break, and we hope to see you all soon. Thanks, bye.